All right, last section that we're going to talk about is reducing and measuring occupational dose, the dose that you as a operator get. And we talk about the 3 cardinal principles of radiation protection, and they are time, distance, and shielding. Time, distance, and shielding. I'm sure all of you are familiar. If you were going to teach a basic radiation safety course, those are the 3 things that we teach students when they're going into radiology, is we always want to keep our time to a minimum, right? Keep our distance that we are from the beam and from the source to a maximum, and use shielding whenever possible for the patient and for ourselves. Somebody asked me over the break, said, well, you know, I do OR, should I wear a thyroid shield? And it's like, why not? You know, if you want to protect your thyroid and you use a shield, it's not going to hurt you, it certainly won't harm you, but they can be hot, and some people just don't like anything like, some people don't like to wear turtlenecks, right? Because they're up on your neck. But if you have one that you can, and have somebody, when you're done with the x-ray, just have them release it and take it off, it will prevent you from getting, it will reduce the dose to nothing to your thyroid. So time, distance, and shielding are our main source. Now, dose limit, what are we allowed to get? What we're allowed to get is much, much higher than what we actually get, believe it or not. We're allowed to get these really high levels, and they keep saying that they're going to reduce the annual permissible dose. Right now it's 5,000 millirem per year. 5,000 millirem per year. And millirem, the universal unit for millirem is called a sievert. Okay? So a sievert, it takes 100 rem to equal 1 sievert. So 5,000 millirem is actually 50, you know, drop 2 zeros, 50 millisieverts is what we're allowed to have annually. But nobody ever gets that. The lens of the eye can have, and the thyroid, both the lens of the eye and the thyroid are allowed, 15 rem. So this is 5. I don't like this slide because it keeps changing units. Do you see that? This is in millirem and this is in rem. So I guess they wrote 15 rem here because they didn't want it. 15,000 millirem is the same as 15 rem, okay? Or 150 millisieverts. Other organs of your body can get about 50 rem, okay? That's 10 times what your total body can get. And your lifetime accumulative dose is 1 rem, or 1,000 millirems, times your age. So depending upon, anybody want to volunteer their age? How old are you? Old, okay, he's not going to tell me. Anybody want to volunteer? You're 71. Okay, so he, at his age, he could have 71 rem lifetime exposure, 35 rem lifetime exposure. You're allowed 5 per year. Okay? Normally, we don't start exposing people until they're older than 18 years of age. If you're below 18 years of age, occupational exposure is only 100 millirem, not 5,000. The general population for protection, and this has nothing to do with diagnostic radiology, but if I'm sitting in a waiting room of a radiology department, I'm only allowed, if I sit there 50 weeks out of the year, 8 hours a day, everybody gets 2 weeks off for vacation, I'm only allowed to, the amount of radiation to come through that wall cannot be greater than 500 millirem, 500, 1/10 of the exposure that an occupational person is allowed to get. Okay, so the public is protected as far as radiation shielding and that sort of thing, but there's no limit, and nobody measures the amount of radiation a patient can get as a result of exposure to X-ray. Yes?
Can you go back over, I'm sorry, but I get real confused with the rad, a rem, a gray, a sievert. I mean, why can't you just use 1 unit?
Okay, well that's a good question. Were you here at the beginning of the lecture? I covered it in the first section, but I'm just curious if you were or not. Okay, so you probably missed this part. But in radiology, we have 3 units that we use for exposure. One is called the rad. Well, let's start with the Rinken. The Rinken, which is exposure in air. The second one is the rad, which is radiation absorbed dose. That usually refers to how much radiation the patient gets. And the third is the REM, radiation equivalent to man. Now, why do we use 3 different units? The reason that we use 3 different units is there's different types of radiation. There's particulate radiation. Particulate radiation has a different energy and a different ionizing capability, we call it the qualitative factor, than X-ray does. So occupationally, not everybody who gets occupationally exposed is being exposed to X-rays, right? Some people may work in a radionuclide lab where they make radionuclides for nuclear medicine. Okay, some people may be working in a nuclear power plant Okay, and they're being exposed to a different type of radiation. So the fact that occupationally people can be exposed to a different type of radiation, they have a unit called the RIM that takes the qualitative factor of the radiation. Let's say we're dealing with X-ray. The qualitative factor would be 1, multiplies that by the rads that you're exposed to give you the RIM. What if I was exposed to 1 rad of alpha particles? What would be my dose in RIM? 20. Yes, 20. You remembered that from the beginning. That's good. So a RIM, we measure our occupational exposure in RIM, or sieverts. And sieverts is just a standard international unit that they use much more in Europe than they use in the United States. But if you were going to talk about Chernobyl or radiation therapy or something where we're dealing with larger numbers, then they will use sieverts or gray. Gray's the other unit. Okay, so exposure in air is Rinkin, also can measure gray, alpha gray, which is in air. The dose to the tissue is in rad, also in gray, G-R-A-Y, and 100 rad equal 1 gray. And then the exposure for occupational monitoring is in RIM, radiation equivalent to man, 100 RIM equal 1 sievert. Okay? And then there's milli, because most of us don't get a whole RIM. So we measure in thousandths of RIM, which is a milli RIM or a millisievert.
I'm sorry, what RIM is what is RIM?
RIM is unit of occupational exposure. The way you calculate RIM is qualitative factor times rad equals RIM. So if you look at all 3 units, let's look at a Rinkin, a rad, and a RIM. If we're talking about X-ray, they're all 3 equal. That's why people are so cavalier about using them interchangeably. Oh, they got exposed to 1 rad of radiation, or they got exposed to 1 RIM of radiation, or they got exposed to 1 Rinkin of radiation. Really, the only incorrect unit that you'd be using there, if it's not an occupationally exposed individual, would be the RIM. RIM is usually, reserved for your monitors, for your film badges and your personnel monitors. But rad and Rinkin are used interchangeably when you talk about patient dose. Rinkin, if you want to talk about it, what it actually means, the number of photons coming out of the X-ray machine. Rad are the number that you're absorbing in your tissue. Does that help? Yeah. Okay, but all 3 are equal. So if I say Rinkin, rad, or RIM, and we're only talking about X-ray today, they're all equal.
5 RIMs per year.
We can have 5 RIMs per year, which is 5,000 millirim. Okay? And then pregnancy, if a woman is pregnant, if you're working around radiation and you're pregnant, your dose automatically drops down to general public because the child is not considered occupationally exposed. So 500 millirim for a pregnant woman, 10 months gestation, it's 50 millirim per month that they're allowed to wear, to receive. Now, do people actually receive these doses? The answer is no. Average whole body dose for an occupationally exposed individual is only 70 millirim, less than 1/10 of what we're allowed to receive. Why is that? Because most of the time when we're exposing patients, we're protecting ourselves, we're standing behind a barrier. We're behind a control panel, we're away from the patient, we have aprons on, we have lead shielding on. So we're not receiving that amount of radiation. And even the amount that you're receiving on your badge outside your apron isn't what your body is actually receiving. It's only measuring the dose to your thyroid and the lens of your eye, or those parts that are exposed. The extremities can endure a lot more radiation than the core of the body because you don't have blood-forming organs, your long bones. So your hands and wrists are allowed greater doses of radiation, your feet and ankles, as compared to your femurs, your humeruses, and your core of your body. 53% of people that are monitored get less than the minimal detectable amount of radiation. 88% receive less than 100 millirims per year. So occupationally, are we really that concerned about the amount of radiation that we receive? No, it hasn't really been a problem in the past. Fewer than 0.5% of the population of occupational individuals receives over 5,000 millirim per year. So it's rare to find someone. Has anybody in this room ever gotten 5 RIM in 1 year? Any cardiologists here? So in your cath labs, what's your film badge readings normally? 10 MR? Or 10 millirim, which is a chest x-ray. Okay. So you're practicing good radiation safety.
What period of time?
Over a year.
1 year. What kind of monitor are you using? Is it film? Is it a film badge? Okay, we'll talk about that. You may want to change out. 95% of occupational exposure is from fluoroscopy and mobile procedures. So that's why we wear aprons. You must wear an apron when you're working around mobile or fluoroscopic procedures to protect yourself. This is where people get the dose. Usually the position of the tube is also important when you're exposing when you're standing around a fluoroscope. The position of the tube, you want the tube, like I said before, the x-ray tube should be under the table and the II tube above the table, although this is not a great setup, okay? So you're a cardiologist, what's wrong with this setup that you can think of?
That X-ray tube would be right beside on the side.
X-ray tube's down here, okay, here's your II tube.
It's too far away.
Okay, this is too far away, that's exactly right. But also, if you're going to tilt the tube, I mean, sometimes the vessels that you're trying to look at, you've got to put angles on the tube to elongate the vessels and to separate them from superimposition. But if you can tilt this away the opposite direction, then you've got the housing of that image intensifier protecting you from the scattered radiation. So all the scattered radiation from the patient is going right to the radiographer. Okay, again, when you're using an image intensifier, you want the tower to be as close to the patient as possible. This is a stationary unit, so as you move the tower, the tube is not moving, just the tower is moving. Time, distance, and shielding. Okay, all X-ray machines have something called a dead man switch. Does anybody know what a dead man switch is? Yeah. Students love this question on exams. They say, oh, it's a switch that, you know, after you stand there, the patient dropped dead.
You drop dead, it goes on.
Right. It's a switch that requires manual activation, pressure to activate it. So you can't turn an X-ray machine on and walk away from it. You've got to step on a pedal, you have to push a button with your hand. It requires manual activation, and you're only making the exposure when you're pushing on the button. If you let go, the exposure terminates. Okay? So one of the things that's hard to teach students is that they have to hold the button down until they hear the beep. Otherwise, they get an incomplete exposure when they're making a static X-ray. And I've always said, if they put beepers on fluoro units, we wouldn't have any problem with overexposure. Have you ever heard somebody take an X-ray? Like in the ER or someplace they do a chest X-ray, what do you hear? Beep. You don't have that with fluoroscopy. If you step on the pedal, you can stand there and gaze at the monitor all day long. There's no beep. But we become, when you work with radiation a lot and you work with equipment, you kind of become classically conditioned. If I'm pushing on a button making an exposure and it's longer than a millisecond, it's like if you go beep, you almost drop the exposure switch because you know something's wrong. You shouldn't hear an exposure that long. We have things called photo timers that count the amount of radiation that the film is being exposed to, and they terminate the exposure. Well, sometimes you can be set on the wrong photo timer. Let's say you're doing a chest X-ray and the control panel's set on the table. So you've got a film in the bucky, you're making your exposure, and you should hear beep, and instead you hear beep because you're not on the right exposure switch. It's exposing the table and not the wall bucky. So you hear that long exposure and you drop the exposure switch because you know you're on the wrong exposure. But I think if we put beepers on pedals with fluoroscopy, people would, first of all, it's annoying. People don't like listening to it when they're stepping on the pedal. But they would be less likely to step on the pedal for as long a period of time if there was an annoying buzzer going off while you're making the exposure. It does make you uncomfortable. And all fluoroscopy machines have to have timers on them, right? Have you seen the timers? 5-minute timers. What happens after 5 minutes? The timer will give off a beep. It will terminate the exposure. Now, normally, if you're on the pedal at the time, you can continue to expose, but if you take your foot off the pedal and try to re-expose, you won't get an exposure because the timers open the circuit up. So keep your time to a minimum. With fluoroscopy, the dose is directly proportional to the time that you're stepping on that pedal. The MA is pretty much fixed. You've got your KVP. It's the time that's the variable, okay, or the number of frames that you're exposing if you're doing a cine run or something like that. Distance, you want to stay as far away from the X-ray tube and the patient. The patient is your source of radiation. Stay away from the X-ray tube and the patient as much as possible. So if you don't need to be in the room, don't be in the room. If you can step out, even if you can step back, there's something called the inverse square law. Every time you double your distance from the patient or increase your distance, the dose goes down by the square of that. So if I'm standing 1 foot from the table getting 100 MR, now I go to 2 feet, 2 squared is 4, now my dose is 25. If I go to 3 feet, 3 squared is 9, now my dose is 11. You go to 4 feet, now it's 1/16 the amount. So simply by backing away because of the inverse square law and the divergence of the beam, distance is the safest and easiest way to reduce your dose. More than anything else, move away. And then shielding. How many of you have aprons that are open in the back? Or do you have wraparounds? Most places have wraparound aprons now if you're doing special procedures and that sort of thing. The only bummer about wraparound aprons is they're heavy, right? So they come with waistbands that you can use that takes the weight off of your shoulders, but of course they weigh twice as much as an open back apron like this one. But you have to be careful when you're using an open back apron that the apron is always facing the beam. If you turn around, what's going to happen? You're going to get exposed. Okay, so if you're working with fluoroscopy, if you're stepping on the pedal and you're working with other staff, be aware of people moving around the room. If somebody turns around and you step on the pedal, they're going to be really upset that you exposed them. And they're going to accuse you of exposing them because they had their back turned to the... So we used to just, when we did a lot of fluoroscopy and we had the old spot films, we used to back out of the room. We can walk backwards almost as well as we can walk forward because, you know, radiologists come in, they want to bang out the exam and get out of there. So they don't, sometimes they didn't care whether you were turned around or not. Once they came along with wraparound aprons, then you didn't have to worry so much about that. But you always want your apron facing forward, not backward. And if you're in the OR, you know, and you've got an apron on, they get really hot, they're under your sterile gown, so you're pretty much stuck with that apron the whole time. So most people in the OR, they want just a front covered apron because of the weight of it and the heat of it as well. But just be aware, if you've got that apron on, to keep your apron facing the radiation source. And then of course holding, the #1 cause of overexposure to any occupational worker is holding patients, okay? We in radiology, we try not to hold patients. You try to recruit someone or incorporate someone in the family, not the mother usually because they're childbearing age, but you know, if you can get a grandmother or a grandfather or a father or someone, nurses usually aren't good candidates either because they're childbearing age and they're being exposed on a regular basis. But anyone other than someone who's being routinely used for, we don't use anyone routinely for holding patients. You know, you don't call Central and say, send up the holder, we've got a patient that needs help. There are different types of immobilization devices that we can use to incorporate. Holding patients is only a problem. There's 2 candidates of patients that we have trouble with motion. What do you think the first one is? Children. Yeah, children. I always say a parent is not an immobilization device. We have immobilization devices. There's something, have any of you ever seen a device called a Pigastat? Yeah, they're great. They work great. People don't like to use them because you have to put the babies in them and arms over their head and they're in a little bicycle seat on a big, you know, tray, and they cry a little bit, but that's usually good because you're doing a chest x-ray and you want a deep inspiration. But it takes a minute to set up, but once you get them in there, they're well protected, there's leaded shielding in it, that sort of thing. Works much better than a mom standing at the end of the table trying to hold their baby while you're exposing them. Okay, so immobilization devices work really well. What's the other patient that we have problems with? Elderly patients, dementia patients, that sort of thing. There's something that we used to use a long time ago when we did IVPs. They were called compression pads, compression bands, when we did intravenous phalangiograms. So for those who remember IVPs before CT? We used to do them all the time. We use a compression band across the patient. Well, these work great. If you're in a position where the patient's going to move, you can put a compression band across them, and it fastens to the table, put one across their knees and one across their chest, and you can really spin them 360 and they're not going to go anywhere, okay, without holding them. So if you need to immobilize the patient, you can use some of those sponges. We always say tape's our best friend. A lot of times we'll tape patients up to keep them from moving. The idea is you don't want to hold the patient during the exposure. Okay, this is showing you the difference with exposure time with pulse fluoroscopy that we talked about before versus the old-fashioned continuous fluoroscopy. So the more exposure that you give them, of course, this is the number of pulses per second with continuous as opposed with the pulse. The dose is going to be minimized. These are 1.6 pulses, 3.1 pulses, and 6.2. compared to continuous exposure. So you get almost a 50% reduction with the pulsed fluoroscopy that you get with the continuous conventional exposed fluoroscopy if you have that. And then again, all fluoroscopic units must have a 5-minute timer. This is for the patient's protection. It's easy for time to run away from you when you're doing an exam and not realize that you've given a patient 5 minutes of exposure. How much would a patient get after 5 minutes of exposure if they're getting an average dose that we've talked about today? About 20. About 20 are. Okay, how much is that for me? That's 4 years worth of exposure at maximum permissible dose, which nobody gets. So it's a lot of radiation in 5 minutes. Now this is just showing the difference in scattered radiation that I talked about if you put the tube above the table as opposed to under the table. Okay? You want the X-ray tube to be under the table here so that the scattered radiation is going down towards the floor rather than out in the room where there's no shielding device. Okay? It's always a better setup. Again, if you're standing right next, let's say you're putting a catheter in, many times we can't use distance. We've got to be standing right next to the patient to do the procedure, right? So if distance isn't an option, then you want to use your shielding, but also set it up in a smart way so that if you can, the scattered radiation, as it is here, the scattered radiation is going to be going in this direction. Here's the beam, and this is the patient, as opposed to if you put the X-ray beam this way, more scattered radiation is going to go this direction because you've got this image intensifier protecting you. Okay? It absorbs radiation and the beam is collimated. The scattered is coming from where? The patient. Then there's this off-focus radiation that I was referring to, also known as leakage radiation or stray radiation. This is radiation that's being produced when you're energizing the fluoro tube or the X-ray tube that comes out of the housing and out of the collimators of the X-ray tube itself. So in this regard, like I said, when we do portables, we stand back 6 feet because of this leakage radiation. And it's not uncommon for a hospital, if they have 40 techs, for 5 of them to be designated as the portable techs. And they do that all. Maybe in OR you have the same techs that come to the OR on a regular basis. They're usually the portable and OR techs, and that's their specialty, and that's what they do because they become more proficient that way. And a lot of techs don't like to go to the OR, to tell you the truth, because it's not always a friendly environment if you make a mistake. So some people, they just refuse to go to the OR. They don't want to go up there and be under that stress. So this leakage radiation it's a real issue, and there is a limit set by the government. You can have up to 100 MR per hour at 1 meter's distance. Okay, how far is a meter? Approximately?
3 feet.
About 3 feet. So if I'm standing 3 feet from the X-ray tube, the exposure to me in an hour's time can be as high as 100 MR. That's 10 chest X-rays. What if I stand right next to the X-ray tube? Now what's my dose? 3 squared is 9. What is it? 900. 900 MR if you're standing here for an hour right next to the X-ray tube as opposed to 3 feet back. Another reason, if you're doing long hours of fluoro and that sort of thing, you want to get that X-ray tube under the table rather than above the table. Get it away from you whenever possible. There's another thing called a tower drape. Now this isn't present in mobile units, but it is present in stationary units. So if you were let's say you're a gastroenterologist and you go down to the radiology department and you do ERCPs and that sort of thing using the fluoroscope, there's a tower drape that hangs from the X-ray tower. Again, look at this technique. Is this a good technique? What's wrong with this procedure, what he's doing here? The tower's it's too far away. It would be better if they brought this tower down closer. It would cut the dose to the patient about half. Just bringing the tower down. The X-ray tube's not moving, but that tower drape, when it's in place, it's protecting the operator from the scattered radiation coming off of the patient. Now, if you're doing a lumbar puncture or you're doing let's say you're doing a steroid injection in a joint or arthrography or something like that, then you're going to have to move that tower drape out of the way. But you can, it's on a rail like a curtain, you can move it back when you're done and fluoro after you've got your position in place. But it's there to protect you. Does it make a difference? Yeah, it makes a huge difference. If you're standing right next to the patient at 1 foot without that tower drape in place, you can get exposure rates up to 500 MR, 5 times what the leakage radiation was, as scattered radiation coming off of the patient. That same position with the tower drape in place, you've just reduced your dose almost 100-fold, down to 5 MR per hour, which is very, very little, okay? Just by placing that tower drape in place. Now, these ISO exposure curves that are here, they're also at the head and the foot of the table, okay? So if you're standing right next to the tower drape, you're not getting that, but what if you're standing at the end of the table, like you're in the OR, you're standing at the end of the table here, there's no tower drape in place, you're still exposed to these same ISO exposure curves coming off of the patient. Now granted, if I'm exposing this patient's abdomen, there's not going to be as much scattered radiation at their head, you know, as there is right next to the table. So it will be inversely proportional to the distance you are from the end of the table. But the idea is the scattered radiation is produced isotropically in all directions around the patient, not just in one. It is greatest at 120 to 130 degrees from the primary beam where the X-ray is hitting the patient, but it is produced all areas around the patient. There was a slide a second ago, this one. This is showing you the exposure here, the levels of dose radiating from the patient. So up in this area, it's the lowest. Right next to the patient here where his hands are, because there's no shield, it's the highest, and then in the table base it drops down again. Structural shielding, if you have a dedicated C-arm or a dedicated fluoroscopic unit, it doesn't require lead-lined walls. So the OR, usually those walls are not lead-lined because what is the primary barrier for your C-arm? The image intensifier. So the beam's not going to be pointed at the walls. The only thing the walls may be subject to is scattered radiation. So normally, if you have a dedicated unit, you'll put it in the room so it's 4 feet away from the closest wall. Then you don't have to shield that wall. If you're building your own suite, that's going to save you a lot of money, right? Because to lead line a room is expensive. So if you have a private office in a medical building or something like that, by positioning that unit far away from those walls, it can prevent shielding. Because with a C-arm or with a stationary unit, the image intensifier itself is going to be your primary barrier. It has to have the beam collimated no larger than the size of the input phosphor. And as you mag it, go to the 4-inch and the 6-inch mode, the beam will be collimated more and magnified at the other end. And no structural shielding is required. This housing itself absorbs the equivalent. It's not made out of lead, but it will absorb the equivalent of 2 millimeters of lead. Okay, so if you have to stand next to something with the fluoroscope, do you want to stand next to the tube or the II? The II, right. That's going to give you more protection. Okay, there's other things that we can do to protect ourselves. We've already talked a little bit about lead aprons. Lead aprons are not optional. They're required by law if you're doing fluoroscopy. I used to work with this radiologist down in San Diego, really nice guy, but he'd come in on the weekends like in his shorts and stuff, and he'd walk into the room and without, I remember one time he walked into the room to do an upper GI, and the patient said, "Who are you?" And he said, "I'm Dr. So-and-so." She goes, "Well, you don't look like a doctor." He came in his Bermuda shorts, and he didn't have an apron on. And he used to not wear an apron in the room when he did fluoroscopy. He said, "I don't want kids, I'm not worried about it." But it's not legal to do that. You need to wear an apron. The people that are around the beam need to wear an apron. If the Department of Health Services in California, if they come out to your hospital and your C-arm is sitting in the hallway or your portable machine and there's no apron with it, you can be cited because there has to be a designated apron assigned to each one of those units. Same thing if your spacer's not on your C-arm and they walk up to that C-arm. If you take a spacer off for any reason, you can get a variance. Let's say you're doing a cross-table lateral hip and it keeps contaminating the field or something like that. You can get a variance from the Department of Health Services to remove that spacer, which is for patient protection, but within 20 minutes of the procedure being completed, that spacer has to be back on the machine, on the unit.
And that's a foot or $20?
It is 30 centimeters or 12 inches. It guarantees a distance from the X-ray tube to the patient of 12 inches or 30 centimeters, actually from the port, the opening of the X-ray tube housing. Okay, now how many of you have seen these mobile shields? Okay, they're leaded glass, or sometimes they can be made of plexiglass. And if you're working in an angio room or a special procedures room or even a fluoroscopy room with the unit, you can place these. People stand behind them. In the OR, they're great to use, so the staff, they don't have to leave, but they can stand behind the shields and not be exposed. There's also leaded glasses. Notice they're wraparound, the sides as well, because X-ray scatters. These leaded glasses can be used. They cost about $200 for a pair of leaded glasses, but if you're doing a lot of fluoroscopy and that sort of thing, you know, they say the threshold for a cataract is an acute exposure of 50 rads. You wouldn't expect to get that type of radiation from you know, scattered radiation doing fluoroscopy, even in a lifetime. Nevertheless, I had a woman just the other day, I was at my, my club, my athletic club, and there was a woman who was an OR nurse, and how old is she? 52 years old, and she's having bilateral cataract surgery. Supposedly the type of cataract that's caused from X-ray, and she blames it on the hospital that she worked at for not providing. She was an OR nurse for 20 years and was standing around the table holding retractors while they were fluoroing, and she swears up and down that her cataracts were caused from that exposure to radiation. She said never was she offered, you know, leaded glasses to wear or even warned about the fact that, you know, if you're exposed to radiation, that it can cause cataracts. Now, it's rare that that happens, but once somebody has a cataract, you know, it's very hard to disprove the fact that it was caused from radiation or environmental radiation or occupational radiation. So it doesn't hurt you to wear a leaded glass. Any kind of glass will protect you more than no glass at all. So if you wear glasses, that's going to help a little bit with attenuating the scattered radiation, but certainly a leaded glass will protect the lens of your eye, which is covered with epithelial cells, right? Those epithelial cells are more susceptible to radiation, and so if that lining of the lens of your eye becomes damaged, the lens will become porous and you'll absorb the fluid from the eye and will eventually cause a cataract. Cataracts take between 4 to 7 years to form with an acute exposure to radiation, and it's inversely proportional to your age. So let's say that you're 50 years old, you'll form a cataract faster than a 30-year-old given the same acute radiation exposure. And it was when they developed the nuclear accelerators. The physicists during that time in the 1940s and 50s, all these physicists who used to steer the beam with their visually, they all developed cataracts within about 10 years. And so there's studies you can do to read about it, but certainly radiation can cause cataracts, and you need to protect yourself if you're concerned about it. What about aprons? How thick do aprons have to be? Well, all radioactive radiation protection devices have to be a minimum lead equivalency of 0.25 millimeters of lead. So most of your aprons, your tower drapes, your bucky slot covers, all have a minimum of 0.25 millimeters of lead in them. Just recently, the FDA increased the requirement for aprons for occupational exposure to 0.5. So most aprons that we wear in the department are 0.5 millimeters of lead equivalency. Gonadal shielding, all gonadal shielding has to be 0.5. Everything else is 0.25, half of that amount. So if you're wearing a 0.25 lead apron, it weighs between 3 to 10 pounds depending on how big it is, okay? And it will protect you from 97% at a beam that's 50 kVp. Well, you can say, well, I use 90 kVp when I do fluoroscopy. Yes, you do, but are you standing in the primary beam? No, you're being exposed to what kind of radiation? What kind of scattered? Compton. Compton scattered radiation. Does it have 90 kVp of energy? No, it's going to have less energy because it's already interacted with something. So when you look at these levels, 50, 70, 100 kVp, these are typical of scattered radiation. Lead aprons are not designed to protect you from primary radiation. I went to one hospital and they said, we're going to have to replace all the aprons. Once a year, X-ray departments are required to fluoro all of their aprons to expose them and to make sure that they're not cracked or ripped or broken. In the OR, it's interesting, people like to fold up the aprons and put them in nice little piles. Well, what happens when you fold lead? It cracks, right. That's why we hang the lead aprons. Now they're making aprons out of different material that's much lighter and environmental friendly than lead. Like even barium they're using, dry barium in aprons to make them lighter. But we fluoro those aprons and we check those aprons every year to make sure that they're not damaged to protect you. So somebody said to me, we're going to have to replace all the aprons. And I said, why? Are they cracked? Are they what? They said, no, but when we fluoro them, you can see right through them. And I said, well, yeah. what are you fluorinating with? Well, 90 kVp on the table. Well, I said, yes, they're not designed to absorb primary radiation. It can get through, but they absorb secondary radiation. So there should never be a time when we are standing in the primary beam under any circumstances. If you're going to hold a patient or anything else, you don't want to hold the patient in front of you and be in the beam. You're going to stand to the side or however you need to do it. But the aprons are designed to protect you. These are secondary or scattered, Compton scattered radiation. If you're wearing a 0.5 lead apron, you're going to get, even at 100 kVp scattered, about 75% protection, but at 50 kVp, which are typical scattered photons, about 99.9% protection. Now, there's not much difference between a 1 millimeter lead apron and a 5 millimeter lead apron, 0.5 millimeter lead apron as far as protection goes. What's the big difference? Weight, right. So if you want to get a 1 millimeter apron, you're going to be carrying about twice the weight. If you're concerned about your weight, then it's probably a good thing to wear a big heavy apron all day. You're going to burn more calories. But otherwise, you're going to basically just put a lot of strain on your shoulders and your back and your hips, that sort of thing, if you're carrying these heavy aprons. You're not going to get that much more bang for your buck with a 1 millimeter apron than a 0.5. So most radiologists, most departments now, we use 0.5 millimeter aprons, and it gives you pretty good protection. Okay. Now, what about monitoring? Who should be monitored? Who has to be monitored by law? Anybody doing fluoroscopic procedure and mobile procedures in radiology, we require monitoring for those people. But if you're not getting more than 10% of your dose limit, then by law, you don't have to be monitored. So let's say you wear a film badge for 3 years and your dose limit is minimal, there's no recording, do you need to continue to wear that? If you're doing the same thing that you're doing before, let's say I'm a mammographer and I do mammograms all day, first of all, you're using very low kVp, you're standing behind a shield, do you think I'm going to get any exposure? The answer is no. Most radiology departments, they monitor all of their staff, and the reason that they do that is because we work in all different areas. We'll go to surgery, we'll do a portable, we'll do fluoroscopy in the department, we'll do mammography. We're cross-trained to do everything, so it's just easier and more effective to put a badge on everyone. But by law, you don't have to monitor somebody that's getting less than 1/10 of their normal exposure dose on a regular basis. Is it recommended? Sure. If it's recommended that you wear a monitor, just so you're aware. How many of you work at more than one hospital? Okay, if you work at 2 different hospitals, you need 2 different monitors. You can't wear the one from this hospital over to, St. John's. Why not? If you get an overexposure, where did you get it? Did you get it at St. John's or did you get it here? So one monitor for each place that you work, and it's a good idea to keep your monitors where you work. Don't take them home with you. Don't put them through the washing machine, in the dryer, on the dashboard of your car. All of these things are going to cause problems if you're wearing film. If you're wearing other things, it's not going to be a problem. Okay, if a patient's pregnant, or if a technologist is pregnant, then we double badge them. Okay, we put one monitor. First of all, if they're pregnant, they're probably not going to be working around fluoroscopy, but if they choose to work around fluoroscopy, then they need to be double badged. We put one outside of the apron and one underneath the apron. Okay? And one way to distinguish which badge is which is that you will designate one as red and one as yellow. So we say red neck, yellow belly. So we put one at the neck, which is red, and a red holder, and then one at the stomach, which is yellow, so that you can differentiate which is under the apron and which is outside the apron. Okay, but again, when a technologist is pregnant, what's their dose limit? 1/10 of what we're normally allowed to get. So it goes from 5,000 down to 500. And again, 500 is totally unreasonable because nobody gets that much radiation. Okay? Now, the reading that you're going to get outside of your apron is usually 10 times higher than what you'll get under your apron. Okay? Which makes sense, right? Because that apron's going to absorb all of that secondary radiation. So the dose that you're getting outside your collar has nothing to do with the dose that the fetus would be getting. Okay, so monitoring dose of 100 millirem here. The effective dose to the tissue below that is going to be 1/10 of that amount that the radiographer is getting here at this level. Now, there's different types of monitors. I asked you earlier, what type of monitor do you wear? And he said he wears a film badge. Film badge is one of the older type of monitors. It's the oldest, it's the cheapest form. It's got some problems with it. We don't use film badges anymore. A lot of places are phasing out film badges. I'll tell you why in a second. But there's actually 3 types of monitors that are used. There's more than 3, but 3 that most places use. One is a film badge. The other is called a TLD, which is a thermoluminescent dosimeter. And the last one is called an optically stimulated dosimeter. These 2 are very much like the digital receptors that we talked about earlier. Okay, they're going to be much more sensitive in detecting radiation. The film badge is the dental film that you use in, when you have your teeth x-rayed, unless they're using digital. And what do we say about dental film? It gives you super duper resolution, but what's the one problem with it? It's not very sensitive to x-ray. It takes a lot of radiation to expose it. So film badges they cannot detect radiation at less than 10 MR, which is a chest x-ray. Okay? Now, so you don't really get anything other than background radiation at anything less than 10 MR. So when we look and we say, okay, 90% of the people working in radiology have less than 100 MR. What are they wearing for badges? Film. Okay? You're not measuring the amount of radiation because they're not getting over 10 MR a month. These are measured every single month, right? And in 12 months, if you got 10 MR, it'd be 120. They're all getting less than 100, right? Because they're getting less than 10 MR, so they're not reading. It's not a very accurate means of measuring your dose. Okay? So film badges, they're basically, pardon?
What's the difference in cost?
A film badge is the cheapest way to go. They're about 10 bucks a piece. We use the thermoluminescent dosimeters. We pay $15 each for them. We replace them every 3 months. So you save, as far as, over a year's time. If I'm paying $10 each for a film badge, it's $120 a year. If I replace a thermoluminescent dosimeter 4 times in a year, right, 30 times 4.
$60.
$45, right? $60, right. $60 for the thermoluminescent. It's much more accurate. And then the optical stimulator is even better than that. Okay, so what's the problem with film badge? Well, first of all, this is dental film that's inside of here. So you get a piece of dental film, that you can buy from Kodak, and it's placed inside of a holder. Inside the holder, there is a filter, a wedge filter. So the filter has varying thicknesses of metal in it. So it's got aluminum, copper, and lead in it, and then here you've got air, or actually this is air. So you can be exposed to air, you can be exposed here to the aluminum, which is thinner, or the copper, or the lead. Now, the deeper the penetration of the X-ray beam, the more that filter is going to show up. Remember we talked about scale of contrast? So they can measure the KVP, or the depth of the exposure, by how much of the filter is exposed. So if all of your exposure is only in the air area here, that's going to mean that it was pretty superficial. So they say your skin dose was this, or your deep organ dose, if it went through the lead, it was a higher KVP, your deep organ dose will be this. Okay, so it's sensitive, not as sensitive. Anything less than 10 MR usually will not register on a film badge other than background radiation. They're always sent in batches together with a control badge. So the control badge is kept in the department in a drawer or whatever. When we ship the badges back, the control badge goes with it. When the badges come to us, they have a control badge. So the control badge is scanned first. Any density on the control badge is going to be subtracted from all the other badges, meaning it was somehow exposed or fogged to radiation. Now, the problem again with film is that it is susceptible to fog. It's affected by heat. It's affected by chemicals. It's affected by static. So if you take off your film badge and you throw it in the dashboard of your car every day and it's 110 degrees out, what's going to happen? It's going to be exposed. It's going to look like you got a high exposure. Okay? If you run it through the washing machine and dryer, it's going to be exposed. So film badges are sensitive to things other than radiation. So you can get false readings with them. The other problem is they're not that sensitive to radiation. You need about the exposure of a chest x-ray to expose it. The second type, and this is a fairly inexpensive type, you can wear them every month or you can replace them every 3 months. They can be worn up to a whole year. We don't normally make people wear them that long because if you are being exposed to radiation, you want to know what it is you're being exposed to so you can correct the action. I mean, this doesn't prevent overexposure. We just want to make sure that if you are being exposed, we know about it and can change the situation. So remember when we talked about photostimulating phosphors? And what do we say about photostimulating phosphors? They give off light, right? 50% of the light is given off initially. The other 50% is held, right, in their orbits in that excited state. So in this type of a badge, we have a phosphor, and it's lithium fluoride crystal, not the same as the plates that we were talking about, because those don't hold the charges long. But it's a lithium fluoride crystal, same sort of a wedge filter in there in different crystals. And so basically, there's 4 crystals, 4 wedges. The lithium fluoride crystals are exposed to radiation. They hold the charge in the crystal until the crystals are heated. So when we send them off to be read, the crystals are heated, and depending upon how much radiation is in the crystal, it will give off a proportion of what? Light. So that light is read by a spectrometer, and the dose is recorded at the different levels. Okay? Now the problem with this is there's no permanent record. If I get a high film badge reading, I can always call the company and say, I want to see that film badge and I want it to be read again. Once you discharge the crystal, the exposure's gone. So if an error is made or something, there's no recall for it, basically. But they're very accurate, and they will record doses as low as 5 MR. Okay, so half the exposure of the film badge. So if you try wearing one of these, see if it changes your dose. Maybe the dose is so low, it's not being detected by the film badge, but it would be picked up by this particular unit. And these can be reused. So you ship them in, they send you another one. You keep the badge, and you just open this up. It snaps open. You put the new badge inside and then close it up. They're not sensitive to heat. They're not sensitive to light. They're not sensitive to chemicals. Basically, they're only sensitive to X-ray. The last type is called optically stimulated luminescence. This is just like the one that I just talked about, but instead of being exposed to heat, now I just said that other one's sensitive to heat, but it's really hot heat. It's not any heat that it's in Celsius. It's not any heat that we would get, on the dashboard of your car. You have to heat them up really hot to get the fluorescence. These are sensitive to light, laser light. So it's a laser light that stimulates them to release the energy that's captured in the crystal as you're exposed to radiation. Now the beauty of these, they're a little bit more expensive, but they're sensitive up to 1 MR for your reading. Again, they can be worn for long extended periods of time. We wear them and then we send them in. They put them through a processor where the laser light scans them, measures the amount of light that they release, and gives you a reading. So the best type of monitor to wear is the optical stimulated dosimeter, luminescence dosimeter. Second best would be the TLD, the thermoluminescent dosimeter, and then the cheapest one, and has to be replaced every single month, is the old standard, gold standard, which is the film badge. Okay, so what's the take-home message of everything that I've been saying today? It's the same thing, is that we want to try to keep the dose as low as reasonably achievable, because any amount of radiation has a risk associated with it for some form of harmful effect. But for the most part, it's beneficial to our patients, right? Okay, questions? We're going to have time to go over the self-test and the post-test as well, since we're a little bit early. Questions, yeah?
Well, I was hoping you could talk a little bit about, particularly the doctors on the mobile clinic. When we look at the image, it deteriorates over time. And one of the most significant things, when someone calls me and says, I got a terrible image, I'd like a little bit more terminology, what's going on, because other than caring for the patient, that's a primary concern is having a poor image, right, or deteriorating one. If we could talk a little bit about that, terms and
okay,
et cetera, et cetera.
Okay. All right. What can cause a poor image? The number one cause of a poor image in an image intensifying tube is aging of the phosphor. So in your normal cesium iodide image intensifier, the input phosphor is made out of cesium iodide, the output phosphor is made out of zinc cadmium sulfide. Those types of tubes, the phosphors do age. In a cardiac cath lab, if you're doing 10, 20 procedures a day, One of the eye tubes may only last you 3 or 4 years before your image begins to deteriorate. So the more you're using that eye tube, the faster the phosphors would, they age like anything else, and they'll lose their ability to produce brightness. Now normally what happens when they start losing their contrast, as we were, their ability to produce light, is the dose will start creeping up. So the exposure rate to the patient, because you have a photocell there that's measuring the amount of light that the image intensifier is producing, if the amount of light starts to decrease, what's going to happen with the generator? It's going to cause the X-ray machine to put more radiation through the patient. The other thing that can happen is the filament in your television camera tube can start to deteriorate. Like light bulbs, filaments, when they get hot enough, they will vaporize, right? As they vaporize, they get thinner and thinner, and the ability to produce the beam that produces your image will get less and less. So as the filament begins to vaporize, your exposure levels in your television tubes will begin to deteriorate. Most of this stuff is a result of heat, long exposures, so you're better off when you're using C-arms and things to pulsate rather than just step on the pedal for a longer period of time. That heats everything up more, creates more heat units. Collimation, that's another thing. Any type of movement, like you're working with mobile units, the cords can become, frayed, they can become detached. All of that, if you don't have good connections everywhere, you're going to have static, basically, and in your imaging. So first thing you want to do, whenever we go up to the OR and we can't get an image, we check all the cords. Is everything plugged in? If you can't get an image, you step on the pedal, check your timer. Your timer switch may be on 5 minutes and you're not going to get an image. Other than that, most of it's going to be collimation, collimating to the area, and a grid's another thing. Most of these units come with grids. If you have a big patient, you want to use a grid. What does a grid do for you? It cleans up scattered radiation. The thicker the patient is, the more scattered you're gonna have. So if you're doing, typically 300 pounders, you might want to buy a grid that's got a higher grid ratio, which is going to clean up your image better and give you better contrast and resolution. Collimation, as we said earlier, bigger patients, you're going to get lousy images on them because what's your image primarily made out of? Scattered radiation. So the more you collimate, the more you limit the primary beam, the more you're going to limit the scattered radiation that's being produced in the patient. Okay? These are all factors that affect the quality of the image. Another thing that people don't think about, and I don't even know if it's available on your unit, but if you're going for fine detail, let's say you're looking at swallowing functions and you're in the neck, which is a fairly small area, you can use a small focal spot. Small focal spot is going to give you a sharper image because it's exposing less area on the target of the X-ray tube than a larger focal spot. It'll give you more blurring, divergence of the rays, sort of thing. So like people that do orthopedic surgery and they're doing hand surgeons and things like that, they'll buy a unit that's got a smaller focal spot because it'll give you higher resolution and better detail.
How about this? The other thing is the clarity of, I guess we're talking about contrast, between the tissue and the background when it starts to become fuzzy.
The tissue in the background. Usually if you're getting a fuzzy image, the number one cause is your OID, how far the object is from the image intensifier. Now you're doing a swallow study, the patient's in a lateral position and you've got the distance of their shoulder to their neck, right? Whereas when they're in the AP position, their back is right up against the image intensifier. That's going to be a much sharper image than this. The way we compensate for that in radiology is we increase the distance, we call it the SID, the distance that the X-ray tube is from the patient. So when we do a cross-table lateral C-spine or a chest X-ray, normally we have the X-ray beam 6 feet away from the patient. So instead of the beam being like this, the beam is more like this. We're using the central portion of the beam that's less divergence. So on your laterals, since you have a fixed distance, you're using more of a C-arm type of situation, you got a fixed distance. On the laterals, you're going to get a blurrier, more magnified image. The only thing you can do, since you can't change your SID, you can't change your OID, is go to a smaller focal spot, which would give you better image resolution.
And the other thing is sometimes we'll see, for lack of a term, black holes. We're looking at the screen and all of a sudden we're seeing holes in the screen itself.
Model the image?
Model.
Okay, mottled is caused by not enough photons making up your, remember X-ray photons are data. So if you're seeing a blotchy looking image, is what you're describing, then usually you need to turn up your MA. No, you can use higher KVP, but higher KVP is not changing the amount of photons you're producing. Photons are data, they produce the image. So we try to keep the MA as low as possible, but if you get with a bigger patient, that's what boost position's all about. What it boosts is not your KVP, it boosts your MA, because the thicker the patient is, the more absorption of those photons you're gonna have, even with high penetration. So if you get a modelly, blotchy looking image, the only tool left in your arsenal, or the gun left in your arsenal is your MA. You've got to increase your MA. It's going to be a higher dose, but MA is going to give you a higher quality image.
I was thinking more that the cesium, the material coating the input phosphor is deteriorating. You're getting kind of holes in that.
Well, we call it snow too, is you're getting a snowy image, like simulation.
It's actually a hole. There's nothing there. We've seen that a couple of times.
Black?
Black.
Yeah. Okay, well, another thing that can happen, when you expose an image intensifier, okay, you don't want to expose an image intensifier to the direct beam because you can burn the phosphor. So normally we don't expose image intensifiers, just step on the pedal and let the direct beam hit them without some sort of a phantom in the way. I saw you do it this morning, I was going to say something, I thought, I don't know. But that's normally when you expose an image intensifier, do a quality assurance test or anything like that, you want to put something in the beam to attenuate it so you don't burn out the phosphor. So you may have burn spots in your phosphor. Any other questions?
Yeah, so if you're a physician that's starting to practice and you bought your CR, how often would you put your phantom in to check your beam?
Good question. Now, if I was using a mobile unit, I'd do it every day. And the Department of Health Services in California, we actually have laws about this, that we're required to check our fluoroscopic units and adjust the contrast and check the exposure levels. It said it should be done daily, but it shall be done weekly, right. So we have logs on all of our fluoroscopes, and we use phantoms. Usually we use a bucket of water, because water does what? It attenuates. We can also use a line pair grid. It's a great way to look at the quality of your image and adjust the quality of your image with a line pair grid. It shouldn't be changing from day to day, but if you find that one day, if it changes by 25%, usually means that the machine needs to be serviced. So in California, they do it once a week, but if you have a mobile unit, you're better off doing it once a day. Another thing that you can use is called a pentometer or a step wedge. Have you seen those? A step wedge has 21 steps on it, and they're thicker. It's made out of aluminum, very thin pieces and very thick pieces, and it's a great way to adjust the contrast on your unit so that you get the longest scale of contrast possible, especially if you're doing soft tissue work. Soft tissue, you want a longer scale of contrast so that you can see that soft tissue. So quality assurance should be done a minimum of once a week, and what you're doing with that, a pentometer, adjusting contrast levels, measuring the KVP and the MA in your automatic brightness mode, and it should stay pretty consistent. If you get a change, like I said, of 25% up or down, means that something's going on with your unit and it needs to be serviced. Okay? On mobile units, again, if you get a pentometer and check it every single day, you're going to have better quality images produced. Yes?
So I think I understand that when we were talking, because our CR is horizontal.
Right.
So we've got the tower and then the IT.
Right.
That if I'm going to try to limit exposure to the patient and to the other people on the band, I need them closer to the tower.
No, closer to the image.
Closer to the image intensifier. Further away from the X-ray tube, the fluoroscopy tube. I was in a van this morning, and the way that you had it set up, and I don't know if they're all set up this way. Okay. The image intensifier is closest to the control panel.
Well, the image intensifier is closest to the back. Yes.
Oh, you're right. I'm
X-ray,
sorry.
yeah, it's close.
Yes, it's close to the back of the van, and the X-ray tube was next to the control panel. Yeah. But I thought you said they stood next to the X-ray tube when they're doing the procedure.
They actually do.
Yeah. Okay.
Because that's where the consistencies are that they use to administer the patient.
Now, just a quick question: why was it set up that way, where the X-ray tube was facing the back of the truck as opposed to the other direction? Just curious.
You probably should have this class. As I say, common sense thing. Common sense is that when you take the X-ray, it's going this way, but after learning about this, the biggest scatter is coming back from the patient to the speech pathologist.
Well, there's two things. You've got that control panel, and I know it's lead lined, and I'm not sure how much lead is in it, but you've got the X-ray tube right up against the control panel with the leakage radiation, and the scattered radiation is coming back that way too. So the best, you know, if it was set up the other way, the leakage radiation would be going out the door and the scatter would be going out the door, and the therapist could stand next to the patient where the image intensifier is, because that's where the patient's going to be. So it sounds like the way it's set up right now, the patient's on the opposite end of the van from where the speech therapist is standing.
The speech therapist could go towards the back.
Good, but the problem is they have their consistency, so they'd always be reaching across the patient.
Or walking across the
And the only way would be to flip it, and there's a way to flip it, but you have to find an electronic device that, if you flip it, the picture's now upside down and around,
Right.
and you can buy an electronic box for about $1,000 that electronically will turn it back the other way.
Well, here's the thing though, look at your monitoring. You know, if you're producing very little scattered radiation, if your staff is getting low exposure rates, then you're safe. I mean, and again, you're dealing with very low levels of radiation. So I wouldn't be that concerned about
Not
it.
that problem.
Yeah. The other thing, I mean, if push came to shove and you were really concerned about it, you could get a mobile shield and stand behind the shield. Yeah.
Here's a really basic question. On a film badge, you said you have to have 10
MR.
MR. Is that like in an instant? Is that over a
No,
month?
over the month that you're wearing it.
And it will accumulate over time?
Yes.
But it just won't light up until it hits that threshold?
Well, anything less than that is going to be minimal exposure. Well, it just show up as background radiation. Okay, so the sensitivity of the film, you know, film itself is not that sensitive to X-ray. The other problem is, you know, like I said, it's sensitive to light, it's sensitive to all sorts of things. So film badges, I mean, they've been used for years, but if you want the most accurate reading, you want to know, I want to know if I got 3 MR of radiation, which is absolute, that's 3 days worth, really. Most people think anything less than 10 is, you know, just a minimal amount, because it's 10 days basically of normal radiation, so they're not concerned about it. But
I guess my question is, could you be getting 9 a day and it recording as 0?
no,
Okay, it is cumulative sometimes.
yes. It won't record, you know, it won't measure out at anything that less than 10 MR, total accumulative dose.
The threshold is the beauty.
Yeah. The other thing that happens with film, and that's just not so much a problem with film badges because you're sending them back every month, but let's say you lose your film badge and you find it a year later and you want to send it in. Well, film ages, right? It's got a life expectancy on it, so, and an expiration date. So film, you have to rotate it and, you know, make sure that you're not past the expiration date, because once it expires, then it becomes fogged. So you can get an inaccurate reading. Okay, other questions?